be talking about a topic which is very common in our day-to-day practice. But unfortunately, though we seem to do wonderful ACL reconstructions with the hamstring graft, why don't all our patients go back to a professional level of play? So I'm trying to present certain tips, both based on literature and my own experience, as to how to optimize your results in your ACL reconstructions. So there are multiple factors. So there's a preoperative, intraoperative, and postoperative factors that are interlinked and that contribute to a good result. So we'll first start with intra-op, which is, for me, is the most important factor. So first thing is do a good examination under anesthesia. Your tunnel positions are of paramount importance. Identify associated injuries. Make sure your graft diameter is all right. I don't like using tourniquets, and present literature seems to support that. And all ACLs are not the same. So have a menu approach for every ACL that you do. So examination, of course, you do your standard anterior draw, but also check your other ligaments and compare with the other side. And many times, if you feel you're a little doubtful, fluoroscopy is a great adjunct that you could use and compare whether there's more opening in your collaterals as compared to the other side in 30 degrees and in full extension. Spend time identifying lesions that are often missed. Most important lesion, the ramp tear. Very often missed lesion. It's important to repair them because they could contribute to rotatory instability and cause long-term failure. These are multiple papers that have been published in this regard. Lateral meniscus root tears. Important to repair them as they are known to contribute towards stability of the knee. And of course, arthroscopy can also be used to identify collateral ligament injuries by seeing more opening on either side. Again, where do we put our tunnels? So what is the ideal tunnel position? So one man's meat may be another's poison. So put the ACL at its native footprint. That's what literature seems to tell us today. So what is the native footprint? Now, that is specific, especially difficult to identify in chronic cases where there's no stump left. So there's a wonderful paper by Robert Magnuson where he shows the ideal tunnel position, which is the green area that you can see here. Now, remember, this is a 3D CT scan of the lateral wall of the notch in 90 degrees of flexion. So it's very important to see what your degree of flexion is on table while you're making this tunnel and try to be near this green area. Improve your predictability of tunnel position. That's important. Where you like putting it, you should put it every time. This is your standard view of in an anterolateral portal. When you see end on through a high anteromedial portal or an accessory anteromedial portal, you see an end on view. So chances of you making mistakes are less. And I have published quite a bit on this. And to improve your predictability, using a high anteromedial portal makes sense. Of course, I don't have to dwell too much on this. Graft harvest, you all are great at it. But make a liberal incision for those who are starting off initially. And those who are doing it on a regular basis, use the mobile window concept, for which you need a good assistant who knows where to show you when. And try to get as much graft length as possible, either by using an open stripper or trying to cut it off as close to the tibia or as close to the tuberosity as possible. Now, what is the best graft diameter? So you need good graft diameter for a successful surgery. So this was a landmark paper in 2012 by Magnuson again. And here he spoke about the 8 millimeter magical figure. But if you read this paper more carefully, he had no revisions in those cases that were 8.5 millimeters or more. So the dictum is at least 8 to 8.5 millimeters diameter grafts produce best results. Are these equatable to our Indian population? Time will tell. There are multiple ways of making your graft thicker. So remember, you need only about 70 mm of graft if you're using suspensory fixations at either end. So focus on your diameter. You can make it smaller. You can make it about 70 millimeters. There are various techniques described to get a 6-tail graft or a 4-tail graft with adequate diameter and length, but which compromises slightly on the length of the graft, keeps it around 70 millimeters. So Do what works for you, but try to get this diameter. Most important, all ACLs are not the same. Preserve the native ACL wherever possible, known as the biological augmentation technique. And there are a lot of papers that speak about this. And I call it the menu approach to my ACL. So all my ACLs are not the same. So bundle specific reconstructions. You may see this very often in your ACLs where you have a continuous stump there, goes all the way. See, stump goes all the way till the notch. So I tend to preserve the ACL as well as reconstruct along with it. Sometimes you may have a specific bundle tone, the other bundle a little lax. So I tend to retension the other bundle and reconstruct the ACL. Sometimes you just have a femoral avulsion with most of the stump intact. If you're not going to do a repair, the Samba technique works very well, preserving the whole stump and passing your ACL through it. And I never stay away from ACL femoral avulsion primary repairs. And you can see one of my cases at 3 years show that it heals beautifully. So it's important to preserve the stump because the stump has vascularity, the stump has proprioception, very important. I tend not to use a tourniquet because there's less swelling, less blood loss, earlier quads rehab. For that, maintaining hypotensive anesthesia with a 90 mm systolic is important. I tie but don't inflate. Preventing infection is the key to success. Of course, IV antibiotics, 1 dose pre-operatively and 1 dose post-op, which most know. Position your patient properly. I like to do all my ACLs on my table. Keeping it down increases your chances of infection, especially when you're working with multiple assistants. And soaking your graft in an antibiotic solution like vancomycin has been proven to show excellent results in preventing infection. And this wonderful paper tends to ratify this philosophy. So I use vancomycin 500 mg in 100 ml of normal saline. I dip my graft and put a gauze dipped in this solution around my graft while I'm doing my ACL reconstruction. Pre-operatively, of course, the prehab is important and proper clinical evaluation. So prehab should be done 6 weeks in advance. Ideally speaking, this doesn't hold good when you have a meniscus tear and you have to repair it. So resistance exercises, balance exercises. And there are wonderful articles describing various prehab modalities. Do a thorough clinical examination. Rotatory instability, identify these cases with explosive pivot shift test. They're not the same. Ligamentous laxity patients. Remember, reconstituting some hyperextension is important. Make your tibial tunnel slightly posterior. The obese are not the same, especially the active obese. So you need to supplement these many times with a lateral extra-articular tenodesis and do not shy away from doing this for extra stability. Examine your patient while walking because you may be surprised on an X-ray with medial compartmental osteoarthritis and the patient having a thrust. So don't shy away from a HTO with an ACL in such cases. ACL done on one side already. So these are not the same cases. Remember, if they're not psychologically confident about their ACL, proper rehab has not been done on that side. They may be prone to a higher incidence of ACL on the other side. So focus on that knee as well. So contralateral ACLs are very common, more common than what you might think, with incidences up to 20%. Post-operatively, I believe in participatory rehab and back to sports, which we'll know about more. So participatory rehab means the surgeon, the physiotherapist, and the patient all interrelated. We need to speak the same language, and it's an integrated approach. Identify not so smooth cases. So if you see a case of effusion, remember, suspect infection. You may have to even aspirate these cases. Send them in. FFDs, reduced range of motion. There's a time when you should manipulate, not just wait that these are all right. And be critical of your surgery. If you have not put your tibial tunnel in the right place, identify these cases at the right time. We'll know more about back to sports with Abhishek later on. There are about 4 phases I follow. And the important thing is to get them back to sport when they basically fulfill 95% of the Melbourne criteria. We'll know more about it later. So my take-home message, spend time and don't miss associated injuries. Have a menu approach for your ACL reconstructions. Don't shy away from add-on procedures like the lateral extra-articular tenodesis, high tibial osteotomy, or the anterolateral ligament reconstruction. And identify complications on time and address them. So little drops make an ocean. Thank you.